My name is Dr. G. Welcome to That's Unusual, my podcast uncovering the unusual stories behind the world's most interesting people. On this show, we celebrate what makes us different and how we convert those differences into unexpected opportunities. Hi, everyone. I can't believe it, but we are now approaching almost 1 year since I started my podcast. And I must say, it has been one hell of an amazing experience for me, far beyond what I ever imagined. That said, I want to make things even better. It's in my DNA to always be looking for ways to improve. So with that, I want to notify you that I will only be releasing a few more episodes of That's Unusual. But fear not, I just want you to know that I'll be back. Yes, I'll be back with something even better for you. Incredible guests with more storytelling in a new format built around organized themes and seasons. I don't have a name for the podcast series yet, nor a release date, but if you want to stay informed, please go and sign up for future updates by going to weareunusual.com and enter your email. For my loyal listeners, I thank you from the bottom of my heart for giving me your attention. Now that is off my chest, let's get started with the introduction of today's episode. Everyone can agree that our current healthcare model is broken. But the question is, can we fix it from the inside? Or do we need to start from scratch? My next guest, Dr. Rushika Fernandopulle, believes in order to best address the looming crisis, we need to reimagine healthcare from the ground up and build new primary care models from scratch. He is the founder of Iora Health, a next-generation primary care practice designed to restore the humanity in healthcare. In recent weeks, we have seen similar primary care models like Qliance and Turntable Health fold under unsustainable business models. But what makes Iora Health different and successful to date? On this episode, Dr. Fernandopulles will share his secret sauce to success, what he believes is broken in primary care, what the future holds for quality medical care, and the inspirational backstory that led him to start Iora Health. As you listen to this episode, I ask that you reflect on your own unusual stories and unique qualities that can help open doors to unexpected opportunities. And so with that, let's get started. Welcome to this week's episode of That's Unusual. My guest today is Dr. Rushika Fernandopulle. Welcome to the show, Rushika.
Thank you very much. Glad to be here.
I'm so excited to have this conversation with you because I think it's one that it's not just relevant to those in healthcare profession, but it's even more relevant to those that are patients and really receiving care in our healthcare system. And healthcare, of course, has been, not just a topic of importance in today's world and policy, but it has been for the past couple of decades. And that's because a lot of how we're delivering healthcare to some degree is broken. And I want to dig deep into a discussion because you're doing some pioneering work with your venture, Iora Health, in reimagining primary care. But, maybe a good place to start is, what is broken in primary care? Why does it need to be reinvented?
Yeah, so the thing that's broken isn't just primary care. The thing that's broken is healthcare in general. Mm-hmm. Just happen to think primary care is maybe the right place to start to fix it. But healthcare in general in the US and probably around the world is broken. So what's not broken, right? We have amazing technology. If you think about the last 50 years, the sort of new treatments and the imaging we have, it's just miraculous. Mm-hmm. The thing that's broken is how we actually deliver it to actual people. And that really hasn't been innovated in the last 100 years. Think about what happens when you get sick. You've got to, pick up the phone, call the doctor, schlep in, have them come see you. That whole chain is not that different. Going to a hospital, going to the emergency room, it's not really been innovated. And in general, I think it's actually gotten worse. And by what's getting worse, I think at root, it's that we have turned healthcare in this country into a series of transactions, right? Document, code, bill, next, you get paid per thing you do, per doctor sick visit. And so it's become reactive, fragmented, we do more stuff to people. And to be honest, no one gives a whit about the outcomes, actually improving people's health, giving them a good experience and keeping them out of trouble. So at fundamental, I think the system is rotten to the core.
Yeah, and it's so true. I mean, I feel like we're making great advances in terms of our technology and the innovations that we're producing around technology, but we haven't quite innovated around the experience, right? We're just dumping, new technology in an old experience, which ultimately is creating like more friction and actually making the system even worse. How are you addressing that, right? So you've got this Iora Health, which has been around for how long now?
About 6 years now.
About 6 years. So you've probably learned a lot in that 6 years. You as a physician yourself, you could have gone off and, started your own primary care practice and created a model within your own practice that, was built around your vision of what it should be. But instead, you wanted to change the entire system of primary care and create a whole new model that others could apply as well. So tell us about that. Like, what was your motivation to tackle this issue head on, and how did you go about approaching it?
Yeah, so I still remember it was a February day in Boston, and if you've been in Boston in February, it gets dark. It seems like at 3:30 or 4 o'clock. It's cold. I was a primary care doc in a typical primary care practice, and I'd seen 34 patients, and barely had time for lunch, let alone go to the bathroom. And they just put a new electronic health record in, and it was so hard to use, and all these points and clicks, and I couldn't finish the notes, so I had to stay typically 2 hours after work with all my colleagues to finish our notes, or else we get yelled at for not meeting our RV using or meaningful use and all that other crap. And I remember sitting there, and really wanted to go home with a colleague of mine, and she looked at me and she put it really clearly. She said, "Rushika, every day I lose a little piece of my soul. Every day a little piece of my soul, that we went into this to help people, and they come to us with such big needs, and we can help them, but the system just gets in the way. I can't do the right thing." And I said, "You are right." And we talked about the fact that, we have 30 more years to go at the time, before, we could even think of retiring. And do we really want to spend 30 years doing this? And I think that was really the motivation, that like, screw it. We created this stupid system. We could fix it. Maybe what we need to do is stop complaining, and just try and fix the system. And I think that the other insight was, I'd spent a bunch of my career up to then doing what everyone else is doing. So it's not a secret, by the way, that the current system doesn't work. You'd be sort of an idiot not to know that. But everyone that tries to do to fix it is what I call this sort of half-assed incremental change model. Let's take an existing practice, and it's too hard to change everything. So let's just change a little thing, and let's tweak the system here and there. And I think after years of seeing this, it doesn't work. It hasn't worked.
Mm-hmm.
And so the really simple insight was, maybe we ought to start over. Maybe there's something fundamentally wrong. And why are we trying to start with what we have? What if we started from scratch and tried to build a new model? And again, trying to change healthcare, and then primary care is a great place to start, because it's a lever point where you can actually help people. You build a relationship. You can help people, with the upstream care. So helping them exercise more and eat better and get rid of stress. And you can help them with the downstream, help them navigate the rest of the system, the cardiologist, the hospital, et cetera. So primary care is a great lever. So let's actually rebuild healthcare, start with primary care, and build up, right? I think a lot of what's going on now is these sort of ACOs, which is this sort of top down, somehow the hospital is going to tweak the system and make it better. And I think the evidence clearly shows that's sort of a waste of time. And why not start from primary care, but actually rebuild the system on what we need? And it's about relationships, right? So the transactions don't work. Last I've checked, transactions have never healed anyone. So we need to get rid of the transactions and rebuild on this sort of relationship model. And that's what we set out to do. I set out about 15 years ago to start doing that with a little company called Renaissance Health. And that sort of morphed into what we're doing now.
Tell me about Renaissance Health. What was that initiative?
Yeah, so really, so from that moment of, every day I lose a little piece of my soul. At the time, I was thankfully spending part of my time running this interfaculty health policy program at Harvard. And so I think a lot of doctors have these insights, but I had the sort of time and the space and Harvard's time to sort of do something about it. And I said, well, what would I do if I started over? And sort of started doing some research and started meeting with people and thinking about it, and came up with sort of plans of how I'd build this. But then the obvious insight very quickly was, you can think about this all you want. What you have to do is you have to build it, right? You need a lab, right? So I went to all the big health systems in town here in Boston and said, hey, I've got this idea is that we need to rebuild primary care from scratch. Will you give me one practice where I can sort of break the rules and just do things differently? And they all sort of pat me on the head and they said, that's really interesting, son, but our practices are full. We're making money. What's the problem? And I was like, well, care sucks. Patients hate it. Doctors hate it. It's bankrupting the country. But other than that, everything's fine, right? It's hunky-dory, right? But and so that was really the moment where I think anyone who's done this sort of work as an entrepreneur, you realize at some point you just have to do it, right? I tried fixing the system through being a consultant and working in Washington and doing academics, and I realized maybe I just have to do this, right? And so quit the day job and started Renaissance Health, rebirth of primary care. And the idea really was, let's just start over. And I said, I'm a doctor. I could start a practice. I'm just going to start a practice and just do it the way I think it should be. And see where that takes us. So started a practice in, like I said, Arlington, Massachusetts, just outside Cambridge. That was back in 2004, so 13 years ago now.
So, I mean, doctors typically aren't really good entrepreneurs. I mean, what was it about you that you thought that you could sort of enter this crusade and sort of be a pioneer in the space? Because that's one thing to start up your own practice. It's another thing to start up an entirely new model of practices. So what drove you to do that? I mean, what was your, I mean, just tell us about that experience, your entrepreneurial experience.
Yeah, so I had no experience being. I was a doctor, went to medical school, et cetera. I think I had I was a government major at college, and I had spent a little time at the Kennedy School of Government and studying systems. Also, sort of a system thinker. Systems interested me, and I think I realized that this was a system problem, right?
Yeah.
And we created the stupid system; we could fix it. So there was sort of feeling we could fix it, and was able to get a little bit of funding, a little bit of money from an old boss of mine, David Bradley, who sort of I'd gone to meet with and talk about these ideas. And he said, "Well, you should do it," and gave me sort of a little bit of a personal loan to sort of get this going. And I found a partner, a guy named Pranav Katari, who's another doc. And we were maybe crazy enough to say, let's try this. We won't never know if it works if we don't try it. So started the practice. At least it's now in our control.
Did you start? So you just started off with one practice and use that as kind of a prototypic model of what you could expand on, or how did you go about developing the initial practice?
Yeah, so that was the idea, right? So obviously starting one practice is mildly interesting. Being able to do this at scale and being able to, the mission had always been transform healthcare, right? And the way to transform healthcare was not to write books about it, or to be honest, doing podcasts about it, or, that's all well and good, but we have to just find a different model, right? We need to build a different model. It was a bit of the Southwest Airlines theory of change, right? So airlines circa 1980, high fares, crappy service, what changed? It wasn't the government or consultants or authors or academics. It was one thing alone. It was a new entrant, Southwest Airlines, that showed up in the market, decided that they were going to break the rules, or what people thought were rules. They really weren't rules, and simply do it better and lower fares, better service, get customers to vote with their feet. That provided obviously better flights and service to the people on Southwest, but maybe more importantly, it kicked US Air and United and Delta, et cetera, in the behind and said, we better change, right? And that sort of transformed the industry. And you could think of, Apple in the music industry and, go down the list. And that was the aspiration from the very beginning, is we want to transform all of healthcare, but we're going to do it by just doing it, right? And demonstrating this new model. So you got to start somewhere. So you start with a single practice and figure it out, right? You don't figure this stuff out by talking about it or whiteboarding or reading. You figure it out by actually doing it, right? So we just learned, how this model worked and what are the pieces we need and what are the pieces we don't need and how do the payment models work, et cetera, and you learn a lot of lessons the hard way, but you keep doing it.
So did you envision sort of the utopic structure or ideal structure of what a healthcare practice should be and then reverse engineer that and test out different things? Or how did you go about develop? Because you have a unique model that involves a completely different makeup and dynamic of who the health professionals are in the system and what it actually entails and covers for that patient experience. How did you go about selecting which ones were important for the practice?
Yeah, then we start with a couple of principles, right? And the first one is that our job is not to channel Clay Christensen. It's about jobs to do. What's the job we do? And I think in a typical practice, your job is to walk in the door in the morning. I have 30-something patients booked in 7 minutes each. My job for each patient is walk in the door, do the best job I can to recommend what they should do, and then walk out and document, code, and bill, and turn my brain off and go to the next patient, right? And your life is this never-ending series of that. And we said that's exactly the wrong thing to do because it's not effective. The thing we should do is I have a population of people and they are my problem. And how do I improve their health and keep them out of trouble and do whatever it takes? And of course, some of it's a visit, but some of it's an email, some of it's reaching out. And it's not good enough to tell people, like in my old practice, I would tell people, look, you should eat less, exercise more, take your medicines. Good luck, sucker. I'll see you in 3 months. Right? And in 3 months, they come back and they didn't do it. And I'd say, you bad patient, you non-compliant patient. You didn't, And of course, if it was that easy, we wouldn't be having this discussion, right? So we need to actually take responsibility for that. And that meant that you had to radically, by the way, empower the patient or the consumer that, at most they're going to spend a couple hours a year. If you add up all the time they spend with you, leaves 8,762 hours, if you're doing the math, that they're not with you. So thinking you could actually manage their health is silly, right? So you need to teach them and their family how to manage their health and give them the tools to do so. So when you start with those, and the final thing is we want to actually build a system that keeps learning, right? The problem with the current healthcare system is not just that it sucks, but it sucks that it can't change.
Mm-hmm.
Right. So we need to build something that can adapt quickly. And so if you take those principles, then you start designing in a very different way. You start building these very robust teams. You start doing interactions, not just by visits, but email and text message and video chat. You start letting patients see their whole medical record, which we were doing in 2004. You take them for walks. You engage them with each other. You integrate mental health into it. You start doing things very differently based on those few design principles.
Yeah. So looking back, if you can remember back, 6, 7 years ago, what were some of the failures at that time that you recognized was not the way forward?
Yeah, I think several. So the biggest failure, the hardest part in healthcare, by the way, or innovating healthcare, is not coming up with the right thing to do. That's fairly straightforward. Mm-hmm. The hard part is figuring out the business model, right? Because almost everything I just talked about, huddles and health coaches and emails and proactively reaching out and mental health, and it doesn't get paid for, right? In some ways, the result of that is you keep people out of badness, out of the hospital, out of the ER, and that's a good way to get fired in a typical health system, right? By lowering their revenue. So the hard part, maybe by far the hardest part, has been how do you figure out business models that actually allow you to do this in a way that you don't go out of business in a few years, right? And that's the problem, I think, with a lot of these innovative, that's a medical home model. It's a great model, but there's no business model to it, right? You do it sort of on, and so that's why it doesn't last. And so that was been the big evolution, I think. And the care model has been largely the same, a little stuff around the edges. Now, one of the things we realized, for instance, is that you can't do this. You can't do it well using existing electronic health records, right? I'm happy to talk more about that. But, there's such a hoo-ha about EHRs and how they're going to change healthcare. They're not. They're paving the cow paths, right? What they do is they actually help you do the current crappy transactional system better and faster. But we need something very different that's relational, that's proactive, that engages teams and patients and, embeds population management into the workflow. And so we just had to build that ourselves, right? So that's one thing we learned, for instance.
You had a little bit of an advantage to that because when electronic health records first came into the market in the early 90s, at least early versions of it, they weren't designed for what we're trying to accomplish today, right? They were designed to be transactional. And now we're basically trying to, retrospectively trying to correct it and design it in a way that can adapt to the current system. So tell us about your model. So how do you pay for, these preventative care and health benefits and coaching elements and behavioral elements of healthcare? Because the system currently, that you can change your practice, but ultimately, how do you change the payment system around that?
No, absolutely. And I think that's the real question. And so a couple of principles. So one is, the way almost every primary care doc in the country gets paid is fee for service, right? You fee per thing you do. That is simply the wrong way to pay for primary care. It's transactional. It encourages you to do more things for people, not achieve outcomes. So we simply say, stop the madness, stop doing it. What you ought to do is we're doing a relationship. So pay for the relationship. Give me a flat amount that's sort of risk adjusted so it's appropriate and let me get on with it, and pay me more if I keep people healthy and out of trouble and pay me less if I don't, right? So the whole spectrum of how you can do that, you can do it through a primary care capitation rate. You can do it through a primary care cap rate plus a bit of a bonus. You can do it through what's called global risk or shared savings. And we've tried stuff along that whole spectrum. I think the key is just don't do fee for service. Now, what's crazy, though, is what that means, though, by the way, is we have to go and find payers who are willing to pay us differently. So we can't just sign, the crappy contracts they're offering. We say, no, you need to pay us differently. And by the way, the proposition is that you're going to double down on the primary care. So primary care is typically 5% of healthcare spending. Mm-hmm. I want you to pay us double that, 10 or 12%. And we will save it on the back end by keeping people out of the hospital, out of the ER, et cetera. So we started way back in the day where the only thing we could do was ask our patients, right? We're going to do something different and we think it'll help you. No one else will pay for it. So if everyone paid us about $40 a month, which is what you pay for your cell phone and your AOL at the time, et cetera, then we'll be fine. And then that morphed into asking employers, right, to start paying the extra for the primary care. Then we got rid of all the fee for service that just pay us a fixed fee. again, employers, union trusts. And then we sort of morphed into working with Medicare Advantage plans and saying, why don't you do this for your Medicare patients? And then we said, wait, the value's all being created downstream. So instead of just paying for the primary care, tell you what, just give us the whole healthcare dollar and let us get on with it. What's profound about this is now no one tells us what we can and can't do. If you think about in a typical primary care practice, people only do what they're paid for, right? And if there's no code for it, they don't do it by and large. We never have to ask the question, do we get paid for this or the other thing? We just do it.
So that's extremely fascinating. What kinds of results are you seeing? I mean, now that you're 6 years into it, is it proving to be cost effective for the payers?
So it is. I'll put a little asterisk by that, and I'll get back to the asterisk in a second. So, we track what we call quintuple aim. So, A, we need a good patient experience. Patients need to want to do this. We shouldn't force anyone into it. And we are. So we're running what's called net promoter scores in the low 90% range, which blows away almost anyone else. In our Medicare Advantage practices, we attracted more patients per practice than I think pretty much any of Humana, who was our big partners, practice in the country. We have at 96 to 98% retention rates every open enrollment. So the experience is incredible. By the way, the experience for the teams, which is the other part, it's got to be good. And we, patients, docs and staff love working for us. Our retention rate's over 97, 98%, right, for teams. Number two, the clinical outcomes. We need to make people healthier, and we're doing that. So our hypertension control rates are in the 90% range. Most people's are in the 60s. Similar as diabetes control, et cetera. We're running 4.5, soon to be 5 stars in the Medicare ratings. Third is cost of care, and we continually see 40 to 50% drops in hospitalizations, about 20% drop in total spend, even when you take into account the sort of extra primary care. And then finally, the fifth aim is really about economic sustainability, and do it at a panel size, where the economics work out to us. We don't go out of business, and we continue to do that. So looking back at the asterisk, right? Why did I put that asterisk there? And it's about time course of the savings. So I don't know why we've gotten stuck. I think the biggest problem facing U.S. healthcare is our short-term timeframes, right? This 1 year insurance cycle, the 3 months sort of quarterly reporting that people have to do. This is really hard stuff. This is about changing behavior, right? It doesn't happen quickly. So when we take the practice with sick people like Medicare or these high-cost commercial people, then sure, in a year or two, we show savings. But when we do this for sort of healthier populations, what happens in the beginning is the cost may actually go up a bit as you do some catch-up care. And it really takes till year 3 before you see significant savings. Now, you see a big savings, but it doesn't come till year 3. And that sort of is what it is. I sort of fantasize if I could only sell 3-year insurance contracts to people. Like we can sell 2-year cell phone contracts, for God's sake, right? So as opposed to, because the biggest problem with all this churn is you make these investments up front and then the patient leaves and you don't get to bear the sort of fruit of it, right? So I think, again, great results with the caveat that in some of the lower risk populations, it may take a while. So again, look at the people who hired us, right? Dartmouth College, right? The Boeing Company, the Carpenters Union in Boston, right? You're a carpenter in Boston. You will be a carpenter in Boston the rest of your life, not going anywhere. People go to work for Boeing. They work for Boeing their whole life. You work for Dartmouth College, 17-year average tenure of employee. We just signed the state employees in Massachusetts. You're a state employee and you're 50 years old, you're not going anywhere, right? That's what you'll do, right? So Medicare, you go to Medicare, you will be on Medicare till you check out the other end, right? With the celestial discharge, right? So it's that's the sort of people that we have to work with a longer term time horizon.
Yeah, it's interesting that this change in behavior is not just about, the behavior change that we need to see in the patients, but it's also about behavioral change that we need to see in the healthcare marketplace.
Yes.
Because the real value add here is, like you said, there might be an initial bump in terms of expense, but you save significantly in the long tail. And the hard thing to measure, though, is predicting whether if I spend more on an individual now, did I prevent some sort of event down the road into the future? And I think it's a hard thing to sort of wrap your head around, saying, well, let's sort of gamble on that and play year to year. I certainly am a believer in terms of, a dollar. What is it? How does that phrase go? An ounce.
Prevention.
Yeah, exactly. There you go. I always get those cliches wrong, but so that's great to hear that the results are panning out. And of course, I think we're even going to see greater compounded results even in the next 6 years. Let's just take. Well, actually, before I get to this next question, does this type of model work better for a particular subset of patients? Is it better for the younger, healthier? Is it better for the older, elderly patient with many chronic conditions? Is it selective to a certain type of patient?
So we've done it in all sorts of patients. We've done it with young, healthy freelance workers in New York. We've done this with older seniors with multiple chronic illnesses in Phoenix. We've done it with the top 10% sickest, multiply chronically ill casino workers. We've done it with Zappos folks. We've done it with college employees at Dartmouth. We've done it with low wage, undocumented, largely women in Jackson Heights, Queens, and it all works. It's always worked. I think that, again, the dynamic is the sicker the group of people, the quicker you can see the sort of economic results. But in general, it can actually work for anyone. By the way, what's interesting is we actually don't do all people in all practices. We actually think that we ought to tune each practice to a particular population. So, we have a practice, that takes care of just seniors in Phoenix, and that they do it really well. And then we have another practice in New York, which takes care of younger women with kids, right? So again, while Iora itself ought to take care of everyone, we think each practice shouldn't try to do all things to all people. Let's actually segment the population and tune each practice to meet those needs. And then, of course, the core infrastructure ought to be scaled like hell across everything.
Mm-hmm. How many clinics or centers do you have?
It's a moving target. It keeps changing because we keep growing and adding things. And then there are a few things that are going away. So at the very moment, we have 35, I think is all I count, in 11 different markets. But we have a couple under construction, and then there are a couple we have on the exchanges that are probably going to fold away. So, like I said, moving target.
Yeah. So the program itself, and you briefly touched on this sort of throughout our conversation, is uniquely different from the existing system. The experience is completely different. Can you just walk us through who a typical patient is and what that experience might be like in coming through the Iora system?
Yeah, I mean, so again, a lot of our growth is in Medicare. So I'll just take a Medicare patient, for instance. So it's actually, I'll tell a story which I think illustrates something about it. So we had a patient come into our Seattle practice. So it was a woman in her mid 70s, had spent her life in Sacramento, and then husband passed away. And so her daughter, who lived in an outskirt of Seattle, said, "Mom, I don't want you living alone. I want to move up here to Seattle and want you to live with us." So the mother sort of packed up her stuff, sold her house, sold the car, and moved in with the daughter. Now, the problem is the mom was sort of isolated, right? The daughter had said, "I'll give you a ride whenever you want to go somewhere." But of course, the daughter was busy herself with her own kids. So the mom felt like, "I don't want to be a burden." So she sort of sat at home and got more isolated, and her health started deteriorating, right? So her diabetes was getting out of control, her hypertension was sort of getting out of whack, just sort of a little depressed. So the daughter sort of found out about us and, signed up for a Humana Medicare Advantage plan and signed her up for a practice. So she comes in, and the first thing we do is we do sort of a very extensive intake. Everyone gets what's called a shared care plan made by the doc and the health coach, right? And then we have a behavioralist. So we sit there, they met there. It takes 1 to 2 hours actually to get to know you and figure out what are your goals for your health, et cetera. And then after it, the team talks. So every morning we have a huddle for 45 minutes. So the next morning we're talking about this patient. We just met this patient. Here's her thing. And then the health coach said, "I'm really concerned about her." The doc's like, "Well, do you think she needs more medication?" And the health coach said, "No, what she needs to be engaged, right? But she's just isolated." And so we have a social worker in every practice. Social worker says, "Oh, we have this group. We have these group visits for everyone. It's called It's My Story, where we get people together once every couple of weeks and just tell their stories to each other." She'd be great in that group. And then the health coach, "That's great." And then the doc, "Well, but the problem is she doesn't have transport. She can't come here. Well, why don't we send an Uber for her?" So we have actually a partnership with Uber where if people need a ride to get to us, we can actually, from our record, just order an Uber. And we have an API, and it just sort of sends a car out to them. And we said, "Well, no, even better. Let me teach her to ride the bus." We're very much into sort of self-efficacy. So the next time the group was happening, the health coach blocked out a couple hours, rode the bus out to the patient's house, and then, gave her a bus pass. Said, "Okay, now let's go into the practice. I'll ride with you to the bus, see how easy it is." "Oh, wow, this is great." Came to the group, loved it, met some people she liked, then on the way back, the health coach said, "Okay, now ride the bus back home. I'm right here on the phone, but call me at every step." And so she did. And she was so proud she learned to ride the bus. And so she started coming into the bus to come to the practice. By the way, she texts the health coach all the time. And then even better, started riding the bus to go visit some of the friends she made in the practice, right? They go out to coffee and tea and et cetera. And guess what? Her hypertension got better. Her diabetes got better. She sends us her numbers, every week, so we know how she's doing, and she got better, right? So it's sort of typical story, right? And I think often the intervention we make is about building this relationship, and often the intervention has nothing to do with medical care, right? So why does no practice do this? Well, there's no CPT code for teach patient to ride bus, right? And
Yeah.
no one would ever think that's part of their job because they think their job is do what I'm paid for, right? And we think our job is we have a population of people, they are our problem, and do what it takes. We hire empathetic, creative people to be able to sort of do these things and just wrap around the patients. Very
So
different.
I mean, so that experience, thank you for sharing that experience. But what I noticed in that, as you're describing that, is about 10 times you mentioned health coach, right? So that seems to be the critical element here, which kind of threads the entire experience together. Tell us about, health coach is this something new that's on the rise in healthcare? Is it a specifically trained individual that serves as the coach? I mean, who is that individual?
Yeah, I don't love the word health coach, by the way. I have these bad memories of a high school wrestling coach drop and give me pointing, right? And feel scarred for that. No, the best word for them, it really was inspired by stuff that Paul Farmer did in Partners in Health in Haiti. And he realized we need these group of people, and he called them accompagnateurs, one who accompanies you in the journey to health. That the job of the doctor is to prescribe, right? But then you need a human being to help you execute on the plan, teach you what the problem is, hold your hand when that's the right thing to do, kick you in the behind when that's the right thing to do. And so we have 3 of these people per doc, and they're picked for one reason only, which is empathy, being able to connect to other human beings, because I can't teach that, but I can find it. And everything else we can train. Right. And we have a own little training program. And by the way, you have to be willing to learn. You have to be from the community you serve, speak their language, live their life. Right. So you reduce the social distance. It is such a powerful thing. Their job is a relationship manager, right? Which no one does in healthcare. And they, have a group of patients. They feel incredibly responsible for their patients. They're advocates. They're cheerleaders. They're mothers sometimes. They're really, that's what they do. And I think they are a big part. And they're in the practice with the team.
But how do you even identify these people? So we have, training for medical doctors, for nurses, for public health professionals, for, other allied health professionals, but there's no degree or training for becoming a health coach, right? Like who are these people?
They're just empathetic people out in the community, right? And by the way, you could find this. We've had 25,000 health coach applicants. These are great jobs, by the way, right? We have a lot of them. These are great jobs. This is the people who used to work at Dunkin' Donuts and Sears and Target and McDonald's and, et cetera, restaurants and real estate. And we don't care where they came from. What we want, though, is get these empathetic people and give them this amazing opportunity to make a difference in people's lives. And then sort of learn. And then we can, the other stuff is easy. I can teach anyone how to take a blood pressure and how to, do an EKG, and they do some of that stuff. But really the point is this interpersonal stuff. And so we select the right people, and then we do the training around the edges, and they get shockingly good. After the first 6 months or so, they get really good. And I think they're the sort of cultural glue in these practices. And really the doctors work for them, not the other way around. We do a lot of interesting things, culturally. So for instance, we have a huddle every morning I mentioned where, we sit down for 45 minutes, the whole team around a table, and we talk about our patients and what should we do, what's the plan. And by the way, not the people coming in, which is what these medical home huddles do. Who cares? They're coming in. We'll figure it out. Let's talk about the people who are not coming in, right, who are getting into trouble. And one of the little things is who runs the huddle. It's not the doctor necessarily. The first thing we say every day is we all run the huddle. We all run the practice, and then we take turns running the huddle. So as a doc, I get to run it 1 out of 12 days, but so does each of the health coaches and the secretary and the nurse and the social worker and, et cetera, right? So I think lots of cultural stuff, but you're right in picking up that the health coach is, I think, the critical piece of all of this.
So this is not how most medical professionals are typically trained, right? So is there a particular breed who's best served in this position, or do we need to rethink our entire medical education system as well in training, physicians and nurses and social workers and so forth to be able to function in an environment like this if we believe that, most primary care practices, will be modeled somewhat after what Iora is doing and perhaps others in the marketplace?
Yeah, you're exactly right. This is not what we're training doctors to do, right? At all, right? And the job of the doctor in an Iora practice is actually fundamentally different. It is not walk in the door in the morning, do your thing with 30 patients, document, code, and bill, right? You don't do that. What your job is, I'm a population manager. I'm a clear architect. I've got a population of people. They are my problem. And I've got all these resources. I've got these health coaches, a social worker, I've got a behavioralist, I've got a computer system, I've got technology, I've got groups I can run, I can advocate to the employer, I can do all these things. And how do I sort of use those to impact my population? And what I'm on the hook for is not RVUs, not number of visits. We don't give a crap. What we do is we track how your experience for both your patients and your teams, your clinical outcomes, and are you keeping people out of trouble? Right? That's what we track. That's what you're accounting for. And so right now what we do is we find the people who already believe, right? So what we're doing is not going to an existing group and saying, taking 10 doctors and trying to convince them all to do this. We're saying, let's find the 2 who want to do this and come over here. And if you don't like this, that's great. You keep doing what you're doing. And by the way, someday we'll probably take all your patients away, right? Because the patients don't want to come over here. But that's how we're going to change healthcare, not by convincing doctors to do something different. We don't convince anyone of anything.
Yeah. When I go on the road a lot, giving talks around innovation in healthcare, I oftentimes talk about the fact that we don't have a shiny new gadget problem, right? A shiny new object problem. We have a people problem at the fundamental core of why healthcare has not necessarily taken a turn for the positive. But that said, innovation around these gadgets and sensors and technologies are occurring. And they do have, digital health tools and so forth, opportunity to be able to continually track and monitor patients when they're not in your facility. Are those tools that you are somehow incorporating into the experience as well?
Oh, absolutely. Because when you think that's your job, of course you do that. Of course you need to communicate with patients. Of course you need data from them while they're at home. Of course you need to proactively reach out. So yes, but so telemedicine, it's not a thing. It's just medicine, right? You just happen to, it's silly to do it just in a visit, right? So of course you should be doing video chat and texting and emails because that's how people communicate in 2017, right? So we just don't make a big deal out of all those things. But when you believe, and by the way, so throwing that stuff into a crappy practice doesn't help either. Right? You have to start by changing the culture and the business model, and then that other stuff will follow.
Yeah, so true. Well, this has been fascinating. So what does the future hold? You're 6 years in. I mean, this is still a little baby in the context of the type of change it can create, possibly over a generation. What does the future hold for Iora?
Yeah, no, we're tiny, right? We're just getting going. We are continuing to sort of improve upon our IT system and our training and our model. We're continuing to sort of expand in different parts of the country and figure out how do we apply this in various different populations. Someday we'll think about doing this in other places. I think the problems we're solving are not just in the US, right? And like chronic disease getting worse. So our last funding round, the lead investor was Temasek, which is the sovereign wealth fund from Singapore. Obviously, there's a lot of interest in that part of the world about these sorts of care models, right? So I think there's a lot of stuff we need to figure out still. And I think the intent and the goal is actually transform all of healthcare. So I think, we're seeing that a little bit in some of the places we've been in for a while, that the other healthcare players start adopting a lot of the stuff that we're doing, and maybe because they need to feel like they have to keep up. And that's great. That's exactly what we want.
Yeah. And you're being humble in saying that you're tiny. You might be tiny in the context of the entire healthcare system, but you're certainly one of the leaders in the space of primary care, driving new models of transformation and change. So congratulations on that. I mean, this is great. I cannot wait to see what's ahead. But this might be a great time to segment into the rapid fire lightning round, which is a Mad Lib fill in the blank. So if you're okay with it, we'll get started. We'll have fun with it.
All right.
All right, good. The first one for you, Rushika, is the best piece of advice I ever received was?
From a high school guidance counselor who tell me when people tell you you can't do things, they mean that they can't do it. So,
I like that. All right, next one for you. I'm most curious about?
It's probably how really to do behavior change. I think at root, what we're trying to do is behavior change. And I think we still haven't figured that out.
Yeah, that's a very complicated thing. We talk about patient engagement so loosely, but there's so much riddled into that and behind that that really is about personalization because everyone's got different behavior dynamics.
Right. So it is not about protocols, right? It's about N of one. Yeah. What's the thing for this patient? Yes.
Yeah. It's almost the antithesis of how we've been thinking about healthcare historically, right? Everything has been sort of this try to fit everything in sort of a standardized protocol, universal size fits all.
Yep.
Yeah. I mean, every behavior is different. All right, good. So looking back, what would you tell your 20-year-old self?
Ooh, I think don't be afraid. Just do it and things will work out.
Yeah, and you certainly took that advice yourself by jumping into it. All right, next one for you. If you had to write a book about yourself, essentially an autobiography, the title of the book would be?
It'd be taking back healthcare. I think that's what we need to do. Healthcare is so important and we have let it be taken over by people who are not doing it right? So we just need to take it back.
Do you think, when you said that, I had a different perspective on that when you said taking back healthcare. So I understand the element of let's take it back and own it and reinvent it and transform it. But also to some degree, I feel like the going back to the relationship and the human experience is almost like taking it back full circle to back in the days of Hippocrates and Aristotle and so forth, and how we didn't have really the technologies and the systems that we have in place today. So it really just was about human interaction.
Yep. Yeah, no, that's great.
I like that title. All right, good. If you could invite 3 people over for dinner, dead or alive, who would you invite and what would you want to talk about?
So I think, Paul Farmer, who's always been a big hero of mine, started Partners in Health, Steve Jobs, and probably Elon Musk. And these are people who tried to, and I think did successfully change the world through things they did, right? Through actually building stuff. And that's what we talk about. How do you do that? How do you sort of overcome obstacles? How do you keep doing it? How do you broaden your impact?
Yep. Very good. All right. Last one for you, Rushika. So on this podcast, we like to celebrate all of those things that make us different, those things that make us unique, and we call that unusual. So how would you fill in the following blank? I'm unusual because...
So maybe I'm really trying to change healthcare from scratch. I think it is so tempting to, start taking fee for service and start working with the health system and start selling stuff to the existing folks. And I think I've been able to sort of resist that temptation by and large and say, no, we're going to stick with it and really do it from scratch. And that's going to be harder and longer and more painful, but it may be the only way we could actually succeed.
Perfect. I love that. That's a great way to close this out. So Rushika, it's been a pleasure speaking to you and learning everything about Iora. But before we jump off this call, for those who are listening, if they wanted to find out more information about you, about Iora Health, about anything else that you're working on, where would you direct them to go?
So they can either go to www.iorahealth.com. It's IORAHEALTH.com. And the joy of having a name like Rushika Fernandopulle, if you Google it, it'll actually pull up a lot of stuff about me. So easy enough to do.
Where did the name Iora come from?
So I was born in a place called Sri Lanka, and an Iora is a little yellow bird from Sri Lanka. I wanted a short name that did not want to do something like Quality Health Partners or yon, right? So let's do something that's fun and short and memorable, and we will add all the meaning into it.
I like that. Very good. Well, Rushika, thank you so much for being on the show. It was a delight talking to you.
You're very welcome. Thank you.
Hi again. It's me, Dr. G. If you are still listening, I'm hoping it's because you enjoyed this podcast. If you would like to hear future episodes, you could really help me out by subscribing to the That's Unusual podcast on iTunes and leaving a review. It goes a long way in helping me get the word out from avid listeners like you. As a thank you, I will be selecting one new reviewer each week at random for a free private 15-minute phone conversation where you can ask me anything and get professional advice on your career or business to help you stand out and make a difference. Also, if you want to be notified of any future episodes, please visit that'sunusualpodcast.com and sign up to receive updates on new episode releases. Until next time, remember to always think unusual.